To mark Human Rights Day, the University of Pennsylvania Law School is delighted to host a seminal conversation between Anand Grover, the former Special Rapporteur, the United Nations Special Rapporteur, on the right of everyone to the enjoyment of the highest attainable standard of physical and mental health, and Professor Jennifer Ruger of the Penn Medicine, who has been described as a beacon for the debate on health policy reform globally. I want to begin by introducing Anand Grover and his seminal work both in India and globally. Anand's preeminent work in the area of human rights has shaped a new jurisprudence in law in India, as well as shaped and informed international norm creation. But I want to take a moment, Anand, to share with everyone the ways in which your narrative arc was bent towards a theory of justice and the influential forces that helped to catalyze this growth. You grew up in Kenya, moved to England to pursue your studies, and then moved to India in pursuit of justice, to quote you and to share with everyone your own ethos of what it means to be both a litigator in the pursuit of social justice. In India, one of the most profoundly affecting moments for you was your meeting with Dinesh D'Souza.
Yes.
Who was at that time in the early 1990s incarcerated because he had tested positive for AIDS. And that became your crusade. And although you lost Dinesh's case, his last words to you made it indelible, shaped in very profound ways the work that followed Dinesh's case. And you said, the promise that I made to Dinesh, I will never break, and Dinesh's work will continue. And your work on behalf of HIV patients, as well as the work on behalf of the gay community, then catalyzed and shaped your work globally. The United Nations in 2008 invited you to take over the work that Paul Hunt had begun, and you were then appointed the Special Rapporteur. And this is really the only special procedure of the United Nations that actually quotes Section 12 of a convention, the International Convention on Economic, Social, and Cultural Rights, the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. And you shaped that mandate in very different ways, and you brought a very alternative thinking to that work. And you continued that work internationally while pursuing social justice reform in India through the Nas Foundation case, the Novartis and the Bayer case, that I hope you will speak to later in this conversation. I want to take a moment now to speak of the ways in which Professor Jennifer Ruger's pioneering work intersects with your work. As I said earlier, her monumental distinguished scholarship has been called a beacon for the debate on health policy reform globally. And I think what is so interesting about her work in comparison with your work is the development of a health capability paradigm, which is really the centerpiece of Jennifer's scholarship, which calls for a pluralistic approach to public policy and what she has defined as a shared health governance model, which I think is very close to Anand's own understanding of a model that calls for shared responsibility by individuals, by community partners, by different stakeholders, and calls for government accountability. So I think those are the kind of analogies, the synergies, and the ways in which your scholarship, your theoretical and philosophical framework intersects with your important global action-oriented framework and the cause lawyering that you have initiated that has pioneered a whole jurisprudence in India. So I am proud and privileged to host this conversation, and we look forward to an exciting and invigorating conversation between the two of you.
Thank you, Rangita. As usual, you're really, you're always making, well, your commendations are difficult to live up to. So I hope I can answer Jennifer's questions with all due respect and responsibility.
Thank you. Thank you for that wonderful introduction, and thank you, Anand, for being here. I wanted to talk a little bit about on health and human rights, particularly the right to health, and ask Anand some questions about your role and your work and your thoughts about the right to health. I wanted to talk first in a broad sense about the conjunction between civil and political rights and economic, social, and cultural rights. So there's a debate, as you know, in not only in the literature but in practice as well, about whether there's a division between those two sets of rights, or whether there's more of a interdependency or interrelatedness between those two sets of rights. And I know that you have a lot of thoughts about that, and I wondered if you'd be willing to share both your thinking in terms of that conceptually, but also your experience in terms of the practice of the implementation of those different sets of rights.
Well, as you know, the International Human Rights Framework has classically made a division between the civil and political and economic, social, and cultural rights. And Rangita is right. You know, your thoughts are shaped not only by what you read and but what you also experience. Mm-hmm. What I call experiential knowledge and abstract knowledge. Both of them shape your thoughts. So my migration from Kenya to England, where my family went from a middle or upper middle class to a low echelon of society, which meant that we were not very well off. Then I had to see the discrimination in that society, which made me radical. And as a student, I was a deputy president of my union, and I became active. So that shaped, and I could see that there was an artifice in the divide. And I examined that, and I found that the notion that economic, social, and cultural rights, like the right to health, is a progressively realizable right, whereas civil and political rights are supposedly immediately enforceable, were based on a very shaky ground. And in fact, intrinsically, the rights were not really different. And this division had come about because of the political modus vivendi, which actually existed between the so-called Soviet Socialist Communist bloc and the capitalist bloc. And one emphasized one, the other emphasized the other. And let me just explain to you, for example, the basis of this rationale or distinction. Civil and political rights are supposed to be immediately enforceable because we have the infrastructure. Yeah. Whereas economic, social, and cultural rights, you need infrastructure like doctors, nurses, ward people, and then health facilities. But both require infrastructure. Mm-hmm. You know, if you take the example of in the US, Mirandizing a person and saying to the person who's likely to be arrested that you have a right to remain silent, and the doctor administering consent or the medical healthcare worker administering consent, both require personnel as well as hospital facilities, etc. But it's an historical accident, as it were, that all those infrastructure requirements for civil and political rights are already met by states. Mm-hmm. And that is because all states necessarily have to impose a rule of law which is coercive. And therefore, to have the state in the first place, you need coercive, armed. You know, Lenin was a person who said that the state is actually oppressive. It's not. I don't agree with Lenin on a number of points, but on that aspect, historically, it has to come about because it has to enforce the rule of law. Whereas it was not thought necessary for the state to actually make sure that in a modern state that they should actually look after the welfare of their citizens. Though that is not accurately, it's not accurate in the sense in native states, like even if you take the Incas. In fact, that's what their role was. They kept the population very happy, but they extracted profit out of them, not in the modern sense of the term. So they actually looked after the population in terms of their basic needs. So it's how you understand the state's role. So intrinsically there is no difference. And take another example. Classically, civil and political rights include what in the United States is the due process clause. That everything will actually be, procedure will be established for a person's liberty or life to be deprived. And that has been incorporated in a number of constitutions, including the Indian Constitution. And a lot of the constitutions in the developing world have been modeled on the Indian Constitution. So you will see that in the Indian Constitution, Article 21 talks about no person's liberty or life can be deprived without procedure established by law, which is a classical negative injunction on the state. And what happens over a period of time, the Supreme Court of India and then a large number of states have incorporated that not to be a purely negative injunction, but have actually read into and interpreted that to mean positive rights. And what is it based on? Actually, it's ironical that it is based, the Supreme Court's case, which is the famous case of Frances Coralie Moulin, an Irish woman prisoner, who said, I am imprisoned, but I should be entitled to, newspapers, literature, what have you, and even healthy food. The Supreme Court said, yes, of course, because the underlying principle of all human and fundamental rights is dignity, which is what was actually enunciated in Moon versus Illinois by the Supreme Court of the United States. So dignity is the foundation, as it were, of those rights, whether it's civil and political or economic and social and cultural. So let us examine, when you are arrested, you're not supposed to be, you're only an accused person in a sense, you're not convicted. But even if you're convicted, you still retain your dignity. Similarly, when the whole issue of consent is based on dignity and individual liberty and autonomy. So the actual foundation of all rights is that autonomy and dignity. So therefore, intrinsically, in the nature of rights, there is no difference.
Yeah.
These are two arguments,
Yeah.
but there are large other number of arguments which I think you've read in my report.
And I think a connection that I would like to make between your scholarship and your framework is you call for fair institutions, you call for fair processes, and your work has been established on a bedrock of the progressive implementation of the right to health on non-discrimination principles, which is not a progressive implementation. It is an absolute right. So I think that juxtaposition and that connection to your scholarship is very interesting.
Well, I think the capabilities approach which Jennifer has actually extrapolated in her work is also very similar to the thinking that I have. I have not actually talked about the capabilities approach, but actually a lot of my practical work as a lawyer and worker of the Lawyers Collective, and even my reports, is based on the empowerment of individuals and communities. That's one of my strongest aspects in terms of the right to health. I feel that if you want to have a right to health framework properly worked out, then the most important thing is that the communities who are affected, they must be empowered, which is actually exactly what the capabilities approach dictates. So I'll give you an example. When we were looking to getting the access to antiretroviral medicines for the people living with HIV, one of the issues was who should be on the table. So we had filed a public interest litigation in the Supreme Court, and the Supreme Court said it's such a complex issue. It won't be easy for us to actually write all the things in a judgment and to try to justify them. And it is better that you actually talk it over, both the parties. And because in India, the PILs, as they are short term, are not adversarial. So we said perfectly, okay, we can do that. So when I went to meet the government, I took all the persons living with HIV, their representatives, and the government said, what are you doing with all these people? I said, well, these are the people who actually are affected. If they are not on the table, then there's no point. Despite the initial reluctance, they agreed. And today they always tell me, thank God you brought those people, because when the rollout is failing, it's not the government bureaucracy which tells them. that things are failing is these people who originally used to send fax messages, then text messages, now they have mobile applications, then they actually feed in the data.
Yeah.
You know, so they are the eyes and ears of the government now, partial eyes and ears. And now you have technological capacities in terms of mobile applications which allow the government data to be supplemented by civil society organizations in the remote part of the country, just sending, oh well, we don't have this, and what about this? So government will say, no, but it's there. So there is already a caution and a caveat entered, and the government is required to check it. So I think that actually indicates that you need to empower or make people capable. And if you don't make them capable, then it's not sustainable. And I'll give you another example from our work with sex workers. In contrast to Thailand, where the 100% condom use was prevailing and it was top-down approach, when the pressure from the government was relented, this thing actually failed. But whereas in India, we said it has to be bottom-up approach. So you have to educate, empower sex workers to negotiate condom use. As a result, whether the government pressure is on or not, the sex workers themselves realize that it's very good for them and for the client. So it's actually become sustainable. Right. So you're empowering people, making them capable to exercise their right, to know about their rights, exercise them, and actually become not the objects of a program, but the subjects of the program.
Right, and related to what you were saying, Rangita, about the health capability paradigm, health agency is a major component of the health capability paradigm. And so it's not just the health outcomes that we're after. Of course, we're after the health outcomes. We want people to be healthy, but we also want them to be able to achieve health goals that they value and enable them to go after health goals that they may be able to achieve. And so the agency aspect of it is critically important. Their involvement in the institutions that are responsible, as you say, they may be involved even in the monitoring of the implementation of the right to health or other types of government policies. So I wanted to push you a little bit more on this this relationship between the different sets of rights. And from the August 2014 Special Rapporteur report, you note that economic, social, and cultural rights, including the right to health, are actually required for the full enjoyment of civil and political rights. And that, to me, is suggesting a sequence or a prerequisite in nature. So just still as we're thinking broadly about these kinds of sets of rights and sort of what might come first, are they simultaneous, or how does this sequence work in your thinking and the practice that you've been involved in?
Let me try to explain it very simply, because in India we had a major debate before the 70s, same thing. You know, they would say, well, you can't have food without free speech. And the other would say, we can't have free speech without food. That debate was settled after the emergency. You can't have either without the other. So it was very clear that, you know, you need both. And actually for me, that's the point. They are interrelated, because can you demand food if you don't have free speech? And obviously you can't have free speech without food. You know, so they are the chicken and egg. You can't actually posit a question which is first and the other. I think that's why human rights and fundamental rights are actually interrelated. They're inextricably linked to each other. So it's only a way of trying to explain and abstract out of it to keep them in different compartments. But the underlying thing is that they're related. You can't have one without the other. So according to me, it's a false problematic for the reasons I indicated. But Jennifer, just to go down to your other point, it's empowering and making people capable is not only the implementation. I really sincerely believe, and I use an example because for me it's been educating myself when I talk to the communities. They don't understand the legal categories. So why is it important that there should be communities affected and all stakeholders to be involved on the decision-making table? I'm not talking about implementing.
Right. Yeah.
Because all of us only understand reality partially. If you want to actually intervene to change things, one has to understand the whole reality holistically. So you only do that provided there is discourse. So I use an example. Forgive me for using that physical example. I can only see your face. But somebody sitting at the other side of you will see your other part. And the whole of you could only be understood by me discussing and discoursing with that person. And that's the basic philosophical proposition, that nobody has understanding of the universal reality. And that is actually based on experiential knowledge, which is then resulting in a discourse. And therefore discourse is essential for understanding reality. It's just not a nice principle. It is very necessary in order to intervene into reality to change it. So for me, the community has more experiential knowledge than people like us who have understanding more of the abstract. It is the marrying of the abstract with the experiential and two views discoursing, or more than two views. That's why all stakeholders must be involved. That's what we found in HIV.
Right.
But as I say, for me, that is a philosophical basis that all must come and say, this is my view. So in my office, in my personal life, I value the discourse I have with other people, because without that, you just don't understand it. I may have violently opposed views, as it were, and we had a discussion with Gilead, we're having a running battle, but at a personal level, I don't have a problem with individuals, And the other thing I've learned is that you don't understand, because the moment you're in a formal setting like this, we are only talking about things which are abstract, which is perforce the way it goes. But when you start eating, drinking, you talk about pain, you talk about laughter, which is different. And that brings on another reality. And I found this to my own advantage. Indira and I done a very important case on pavement dwellers, as you probably know, Olga Tellis case. And we were doing it without actually interacting with the clients. So one day a very, very famous judge, who's no more, Justice Krishna Iyer, who was one of the most amazing personalities of our, not only he was a law minister in the first communist elected government in Kerala, but also the very good lawyer and then the Supreme Court Justice in India. He had retired by then, and he rang me up and said, you are doing the pavement dwellers case, I want to come and meet your clients. And I was, though a left-wing oriented human rights lawyer, I had not very good views about pavement dwellers, because they were people who lived in very difficult conditions, and you develop prejudices and biases, which all of us have. We are brought up with prejudices. So then he came to Mumbai, and then we met people. And how did we actually start talking at a more personal human level was when they offered us tea and something, and we started talking. And then I realized my prejudices about pavement dwellers were completely unfounded. And that brought home to me the reality of things, that we have prejudices. And it's only when we talk to other people, either at a personal level or interact with them at a human level, then you really come to know about the human person in that human being. And that is very important for communities to interact with other people. So I think
different perspectives.
The perspectives which are different are very, very important.
Right. So if it's all right, I'd like to turn the conversation a bit to justiciability and this issue that is very contested still, as you know, especially with the right to health. And wanted to see if you could talk a little bit more about, given your experience and what you've seen in the courts, which aspects of the right to health are clearly amenable to these kinds of judgments, and which ones really we need more confirmation in terms of the ability of courts to handle this, and the justiciability question about looking at the whole category of the right to health.
Well, excuse me, I feel that a lot of the problems in the right to health framework is because the way it has been expounded by us, and a lot of states, even including judges, do not understand it. Whereas all other rights are textual and very easily understood. This, and they're very narrow, very specific. The right to health framework is very expansive, based on other determinants and social and physical. So what happens is, it's a nuanced thing which you have to appreciate. So one of the major problems I felt was that people just don't know much about it. So that's why court says that, oh, I remember when we were doing the access to medicines case, Justice Ravinder said, but what can we do? It's the right to health. What are we supposed to do? So anyway, this was a problem. And that's why one of the things that I have done is actually brought to the internet and available to people online free of charge, Global Health and Human Rights database, which is freely available, judgments from around the world which are translated into English and summaries. So we will learn from the Latin American experience and African and Asian, and now we have a huge set of judgments from all over the world. But really, I don't think there's much of a difference, because take the example of judgments from South Africa, which is the right is very similar to what is in the International Covenant on Economic, Social and Cultural Rights. So you had examples from that where the TAC case, you're familiar with it, Treatment Action Campaign, where the issue was whether a particular drug which was required for mother-to-child transmission to be prevented, nevirapine, and it was used in pilot sites for feasibility studies, whether they should be available to the public at large. And the government said no, because safety and efficacy may be an issue. And the court ruled saying that safety and efficacy is already demonstrated. So the only issue is whether you should carry it out in pilot sites or make them available generally. And as large number of women needed them for preventing mother-to-child transmission, they said they ruled that they should be available generally. So you have a concrete instance. So similarly, the Inter-American Court in Yake Access case, where the issue was with native communities have been displaced, and they were actually roaming around in different parts of the country, and they did not have access to health facilities. Again, the Inter-American Court, relying on the right to life principle in Article 4 of the American Convention, they said no, they have a right to life, which includes the right to health. So it has been adjudicated, it's enforceable. And I think to a large extent the debate is still now, because there's an optional protocol on the ICSR, SCR, and where if the states have signed on to the optional protocol, then you can go to the SESCR committee and actually adjudicate those rights. The manner of adjudication and the manner of orders may be different. Like, for example, take an example of, okay, should you have medicines for hepatitis C? We've done that with ARVs as an example, but now say hepatitis C. Most countries do not have programs, including the United States, for hepatitis C deliverance right across the country. There is no testing, there is no program for making it available. So how would you do it? You would say, okay, it is a core obligation, immediately enforceable, but the practical rolling out of it will take time. Okay, so but you need to have a plan. The plan is immediately enforceable.
Right.
So where is your plan is the court's question. So you would actually say, give us a plan, give us the datelines for everything, and we'll see whether it's okay or not. Are you going to take 2 years, 10 years, or 20 years? So court can look into that and say, this is what is acceptable. And they will say it's reasonable, considering the resources, considering the actual feasibility of putting it. So I think now it's not a question, because we know a lot about how things work. Of course, the government will come and say, these are the difficulties, but they will be objectively examined. So the same criteria we use for administrative law, is it based on subjective satisfaction of the government or based on objective criteria? So those questions would arise. I think it's an exciting area for a lot of countries to look into now.
But I want to point out the real power of Jennifer's question on the justiciability of programmatic rights. As you have pointed out, it calls for resource allocation on the part of the government, and the government making some difficult choices, even when the government wants to do good. So like in the case of the anti-retroviral case in South Africa, the government had to make a distinction between women prisoners and women prisoners who were pregnant in allocating antiretroviral drugs, and that was a very difficult choice and was challenged in the Supreme Court in South Africa.
Well, those, I think there the question is, as you rightly indicate, the right to health also has a justice element, which is what we are talking about.
Yeah.
But those issues, I think, as I understood Jennifer's question was, are these matters which can be handled by courts.
Yeah.
So I think these
Yeah.
are very much amenable now.
Yeah.
We have much more knowledge and information, and they can be tested.
Right. I think this, adding to your comment and question, I think the issue of states' resources is critical.
Oh yes.
And so getting to the progressive realization, which is really much of the focus now, especially with the global health policy focus on universal health coverage, as you know, the Sustainable Development Goals, and much more focus on thinking about the health system as a whole in countries and how the global health community can support that system. The question is how to critically analyze or think about the allocation and use of resources at the state level, and whether or not these domestic governments are efficient in their use, their allocation of the resources. Are they using them well? Is the population at large, being covered in terms of equity? And how to critically think about that at the state level, given that there are different health systems that have very different principles and different resources in their command?
Well, I think I'm glad you raised this question, because this has been taken up by a large number of people. And in the paradigm of universal healthcare, this question arises quite sharply. And the answer actually is not to do with, how states efficiently allocate only, but whether they have the resources in the first place. So we know now, and Jeffrey Sachs has done a lot of maths on this, we don't need that much money for the basic healthcare facilities and goods and services. The question then arises whether, for a very nuanced surgery on particular thing, which may cost a lot in certain countries, whether that should be available at state's expense. But basic preventative healthcare, and a very good example is the difference between Sri Lanka and India. I mean, Sri Lanka with very little resources, because they had in the early part of their, after independence, dominated by sort of socialist thinking, they put money in primary education and primary health infrastructure. You can see the results today. They have better healthcare system than a lot of developed European countries, whereas India made the mistake of not doing that. So today we have to think first of the preventative thing, and then build on that. So for that, you don't need that much money. You need, according to Jeffrey Sachs, about $40 per capita, but put it at $100 per capita today. How would states raise the funds? Okay, middle income countries can do it fairly simply, but there is a difficulty for the least developing countries. But we have an answer in an example of the Global Fund, where it was of course driven by charity. I don't think it should be driven by charity. It should be owned by all states, where every state will put a bit of money in it, depending on their availability of resources. So a country which is very poor may put even $100, and India may put $20,000, and the US may put 10,000. But it is actually to make sure that everybody is entitled to basic healthcare facilities, goods and services across the world, and similarly in education, because that augurs well for development generally. We know and Amrita Sen and a lot of other people have pointed out how these issues like education and health actually are very intimately linked to development. And we saw the fruits of that in Southeast Asia, and South Asian countries have also taken it on board on educating the girl child, because then you have multiplier effects in terms of the young woman being empowered, saying, I don't want 10 children, I only want 1 or 2. I would rather have a girl child. So you actually have a huge benefit in the not in the long term, but in the medium term. And that actually is spreading as an understanding with everybody. Whoever now becomes educated, the mother say, we don't want 2, 3 children, we want 1 or 2, whether they are from a poor strata, but if they have the information and education. And I've seen that in India, the way it's changed, people moving from the rural areas into the urban areas, they have the advantage of education. They said, oh, my father had 6 children, but I don't want more than 1 or 2, So it's a big change which is happening, and we have to capitalize on that. So spend on education, spend on health, And within a decade, you see the changes.
Right. So you started to talk about the obligations of international actors. You talked about a global fund. And presumably that's expanding the current global fund, which is focused on 3 diseases, to be more broad and to support the health system at large and to support investments in the right to health. And so could you say a little bit more about the tension or the relationship between international or global obligations for the right to health? Here we're talking specifically about the financing of it, and the state's obligations. And it is true. I mean, if there isn't enough money in the domestic case to support investments for the right to health, then there are international obligations that kick in. The question is how much and what role the international community plays vis-a-vis the domestic community.
Well, there is the element of international cooperation, which is also very important in the human rights field. But the real question is, are the states prepared to put in money? Well, a very good example has been HIV. And the US Presidential Emergency Fund is a huge amount of money allocated by the US. It has to be appreciated. But whatever they see in terms of merit of that, and I heard some people talking about security being one of the issues. Health security is a very important issue, apart from military security. So I think once states realize the advantage of something like that for the whole world and even for their own interests. I mean, you know, if you have poverty, you have ill health, you actually breed conflicts, you breed violence in societies, which doesn't augur well for any stability in any country. And even if you look at it from a profit-oriented point of view, are you going to invest in a country which has instability? Obviously not. So it's axiomatic that if you actually have better health, better education, you can invest in those countries. So I think the long-term advantage is for governments to be able to say, okay, we are all ready through the UN system. Every country will contribute, and you have a system which is fair and transparent, which is managed by professionals who allocate the resources according to the demands and also the need. I think it's a very difficult proposition in terms of implementation, but the idea has now become very important because we've had a good example in HIV, but there it's based on charity and only few governments contributing. I don't see why India, China, Brazil also should not contribute.
Right.
And they can contribute. They are actually putting money in aid, but those are for political reasons. They can still do that here and use that. And I think all governments which have the money, they do put money for the other countries. But this will be more efficient use of resources than just putting in money for in one country or a couple of other countries.
And how does this relate to the use of or the exercise of other multilateral institutions like the World Health Organization, the World Bank, and this sort of international cooperation around health to support the right to health? So we've just been talking a lot about the financing of it, but there's also the governance and the other aspects of cooperation that are important.
But the World Health Organization is different from the IMF or the World Bank. And the World Health Organization actually is now suffering lack of funds. So I think government should actually put in money, because otherwise you have private actors coming in. And the problem with that is that unwittingly the private actors start dictating the agenda, which is not a good thing. So I think private funding in an institution like the WHO should be limited.
The extra budgetary funding,
I think that should be limited, and states should actually put more money. But in terms of IMF and World Bank, unfortunately over a period of time they've had their own prescriptions which have resulted in disaster. There is a correction mechanism now being undertaken, but I think they have the problem with financial institutions is that the way the whole institution is structured in appointing people and the ideas they bring on the table is not conducive to real debate. So I think those need to be corrected over a period of time.
So the governance within those institutions is,
from
your perspective, flawed and needs reform.
You need to have different views also. I mean, this is a very singular view in the monetary institutions, which doesn't actually augur well for a lot of the economic, social and cultural rights, because they have been bent upon privatization of a number of facilities, which I don't think is the correct prescription.
Mm-hmm. Mm-hmm. So in terms of the equity implications of the right to health, or trying to implement the right to health, could you start talking a little bit about vulnerable groups and particular groups in society that may not have the protections that, or may not be included even in policies that are being implemented under a right to health, and ensuring that those particular groups, and even there's some question about what that means and what the definition of that from the general comment, and sort of how that can be expansive, or what groups are included in. But it's very important from an equity perspective that certain segments of the population are included in these kinds of progressive realization implementations.
Well, one of the elements of the right to health framework is non-discrimination.
Yes.
So an equity is written into that.
Yes.
Because services, facilities and goods have to be delivered in a non-discriminatory manner. But the right to health framework also understands that there are people who are more vulnerable to a particular ailment because of predisposition of that particular ailment towards those people, or within that community or those communities, because of practices, because of inequality. Now, classically, say for example, women, because they are less empowered, they are unequal qua men in their relationships, they are actually more vulnerable to diseases. Take an example in a country like India, where a young girl who's not educated, but she falls in love with a man and has penetrative sex without condoms, she's likely to become HIV positive. But even if you take another woman who's educated and her husband is a bit of a philanderer, and is she going to tell the husband, no, unless you wear condoms, I'm not going to allow you to have sex with me? No. Because of the power relationship which exists in these intimate associations, inequality plays a role in actually making people disproportionately impacted and vulnerable. So these have to be taken into account, not only because it's a good thing, but if you do not actually provide extra services, in the sense, look into the vulnerability of certain communities, which may include immigrant, migrant, women, transportation workers, those who are away from the family for a long time, or they are marginalized like gay men or transgender people or what have you. If you don't look into it, actually it starts kicking into the mainstream. So there's a very interesting kind of saying by Justice Michael Kirby in the HIV scenario, that if you want to protect the vast majority of the people, then you must protect the rights of those who are vulnerable. This is the sine qua non of a proper right to health framework, where vulnerable groups actually have to be part of the system. Decision-making table, implementation, monitoring, and they come within the whole response. They are no longer the objects, they are the subjects. So I think that is very important. The right to health framework recognizes vulnerability, vulnerable groups, and to understand those and bring them onto the table.
No, that's really very, very important. It's been a major issue, I know, with the implementation. I want to ask you a little bit about enforcement. Which is a real challenge, as you know, enforcing the legal judgments that come out of this realization of the right to health. And so what role different actors have in enforcement? So we have the courts, of course, we have state governments, we have the public, we have different groups that may be affected, stakeholders, different communities, and sort of what, can you talk a little bit about enforcement and trying to make sure that legal judgments that come out of the right to health and all the work that's being done are enforced and are working properly?
Yeah, I mean, we learned in India, but in the Lawyers Collective long time ago, that if the community doesn't have ownership on rights, then these judgments may remain on paper. You can have contempt action, etc. But unless there's a demand from below, there'll be nobody to oversee them. That's why the community participation, being the ears and eyes of whatever is implemented is not only important from the point of view of deciding what should be done, but they are actually people who own the process. So we had a very important case long time ago on rural employment guarantee, and because there was a trade union working on that, we saw that unless there is a group of people who work on that issue at the local level, who can own the process, you will not be able to implement it in developing countries. So we don't go as lawyers collective file litigations just in a name. So we say, okay, let's see what is the situation on the ground. Do you have any processes working on the ground with the communities involved? So if there's a favorable decision, they will be the ones who will actually own up to it and make sure it's implemented. So as I said, the actual involvement of those who are affected is not only important for decision making, but actual final implementation. If they are not there, it will remain on paper. That's why for me, participation and non-discrimination and equality are the most important principles in the right to health framework, apart from autonomy. These are the most important, in terms of actually seeing that things work. And you see, wherever that has happened, things are working. Because on the ground, people see, this is what I argued, this is what I got, and now I want the actual fruits of the labor. And that's, I think, is the best way to ensure success and in its final stages, as it were.
And in terms of specific monitoring mechanisms, do you have some thoughts on best practices or what you've learned from the natural variation or experimentation that's occurring throughout the world in terms of types of monitoring mechanisms that are most effective?
No, I'm a great votary for communities, and this also came in the Fukushima disaster. When they did not, the Japanese have a peculiar view of participation. They think that elected MPs are the route for participation. Whereas when the Fukushima disaster occurred, the persons with physical disabilities got houses which were completely unsuitable to them. So because they were not involved in any decision making.
Right.
So I think the community is a sure way of making sure that you will get some success. There's no guarantee for everything, but it's better than not. And even in developed states like England, I've seen where policies are being put out which don't involve the communities. Like my brother works very strongly on anti-racist activity. So when solutions were sought to be found, how the police should sort it out in terms of treating people of a different ethnic community. And the main thing was involving people who have been affected. Like, for example, in racist murders, the families of those victims were involved in actually developing a response along with other stakeholders. And that ensured that over a period of time you have accountability, monitoring, better relations between the police and different ethnic communities. That's how you should do it, because everybody has a point of view. And the people who are most affected, if they own up the process, then you have a sure way of getting success.
Thank you, Jennifer, for those very thought-provoking questions that really catalyzed a fascinating conversation. I learned a lot, Anand. And just to sum up very briefly some of the overarching themes of this discussion, you reminded us yet again that rights are inextricably interlinked and that there's no hierarchy between the two major human rights covenants, the International Convention on Civil and Political Rights and the International Convention on Economic, Social and Cultural Rights. In answer to several of Jennifer's questions, you responded to the importance of the ownership and agency of all stakeholders, including the subjects of the right to health. The fact that the right to health is built on the twin pillars of non-discrimination and equality, the role of national, transnational, multinational institutions in advancing the right to health and the enforcement and the monitoring of right to health is really both at the community, the national and the international level. And finally, I think if there's one takeaway that we can take from this conversation is that national security is health security. So I think that is our message for the International Human Rights Day 2015.
Thank you very much.
Thank you.